Hello everyone and welcome to my channel. Today we are starting from the upper GIT unit of systemic surgery, and we have already discussed the breast portion, the thyroid portion and the orthopedic surgery portion. Now we will discuss the systemic surgery portion of the upper GIT. So starting from the esophagus, first of all we are having the topic GERD. We are having a scenario in which states that there is a middle-aged obese woman having burning pain for few months. It is localized to middle of the body of sternum, no pain radiation, which relieved with antacids. Pain shortly come after meals. Disturbed sleep happen if she slept propped up with pillows. There is no history of dysphagia. Diagnosis, clinical features, complication, and treatment is asked. So coming towards the definition of GERD, it is reflex of gastric contents into the lower esophagus. Normal phenomena, but when cause symptoms, it is called GERD. There are the causes. These are increase in transient lower esophageal relaxation, defect in lower esophageal sphincter. Other factors are pregnancy, obesity, fat, alcohol, large meals, spicy diet, smoking, and hiatal hernia. Now we are having two broad classes of the GERD. This is acute and chronic. The acute state is due to alcohol and stress, while the chronic is due to hiatal hernia following esophagogynostomy, structurally defective lower esophageal sphincter, inadequate abdominal length that is short esophagus, ineffective esophageal pump affecting clearance of the food into the stomach. Increased gastric pressure can occur due to pyloric stenosis and diabetic gastroparesis. Now, what are the clinical features? These are both typical symptoms and atypical symptoms. In typical symptoms, we are having heartburn, that is retrosternal burning sensation, regurgitation, that is effortless regurg of the sour and bitter contents into the throat, and then the dysphagia. In atypical symptoms, we are having reflex of the gastric contents into the larynx and trachea, asthma, cough, laryngitis, sore throat, non-cardiac chest pain. Now, in investigations, we will do the endoscopy, that is upper GI endoscopy, esophageal pH recording and impedance test, contrast radiography, barium swallow and meal, Bravo pH monitoring, high resolution esophageal monitoring. In management, we will provide the supportive management, the medical management, and the surgical management. In the supportive management, we are having weight reduction, stop taking acidic food and fatty acids, take small and non-spicy food, quit smoking and acid and alcohol, avoid coffee, chocolate, and coke. In medical management, we are having 8 weeks course of PPIs, esomeprazole 1 to 2 months or until symptoms are relieved, prokinetics, that is etopride 50 mg 2 to 3 times per day for 8 weeks on empty stomach, mucosa protecting agent, sucralfate, endoscopy to non-responders, maintenance therapy in case of erosive esophagitis and Barrett's esophagus, H2 receptor antagonist, and PPI is safe in pregnancy. In surgical options, we are having the total fundoplication, that is NISSEN procedure, the partial fundoplication, and the laparoscopic fundoplication. In the complications, we are having stricture, esophageal shortening, Barrett's esophagus, and esophageal carcinoma. So, what we have discussed in the first topic of esophagus, that is GERD, the causes, the types, acute and chronic, the clinical features, which are both symptomatic and asymptomatic, the investigations, the management, the medical, surgical, and supportive management, and then we discuss the complications. Now coming towards the hiatal hernia, it is hiatal is defect and hernia is whole, so part of the stomach protrude into the thoracic cavity through side of esophageal hiatus of the diaphragm. The pathophysiology is phrenicoesophageal membrane normally surrounded lower esophagus and fixed into diaphragm. Defect in phrenicoesophageal membrane led to hiatal hernia. What are the types? We are type 1 sliding hiatal hernia, type 2 paraesophageal rolling hernia, type 3 mixed hernia, and type 4 is massive hernia. In type 1, we are having gastroesophageal junction moves up into the thorax. The clinical features are protrude symptoms like reflux esophagitis, more common in women, especially obese. The complications are GERD, esophagitis, Barrett's esophagus, esophageal carcinoma. The others are pneumonitis, asthma, and the cough, etc. The type 2 is paraesophageal rolling carcinoma or rolling hernia. This is all or part of the stomach herniates into the thorax, immediately adjacent and to the left of the undisplaced gastroesophageal junctions. Since G junction remains intact, reflux of the gastric content into esophagus is not common. The clinical features of type 2 are no sternal pain or burning, discomfort after small meal, palpitation due to compression or heart, respiratory infections and hiccups due to irritation of the phrenic nerve. The complications are hemorrhage, strangulation, obstruction, gastric ulcer, and bleeding. In the type 3, we are having mixed hernia, which is a combination of type 1 and type 2, the herniation of greater curvature of stomach and gastroesophageal junction into the thorax. In type 4 is the massive hernia, which is abdominal contents in addition to the stomach hernia. Typically, large hernias contain spleen colon in addition to the stomach. Now coming towards the investigations and the treatment options for hiatal hernia, these are the X-ray chest is done, measure air fluid level in mediastinum, barioswellum is done, method of choice which is endoscopy, esophagoscopy, reflux of the gastric acid most valuable sign. The treatment options are asymptomatic sliding type 1 requires no treatment, sliding hernia associated with GERD medical therapy, and for type 2, 3 and 4 cause complications operative repair is required. Now coming towards the achalasia. Achalasia is the failure to relax, motility disorder of esophagus, only motility disorder whose etiology is known, high lower esophageal sphincter pressure, loss of ganglionic cells in the aerobic plexus. The clinical features are common in middle age, that is 25 to 45 years, dysphagia and regurgitation occur. Investigations that we will do for achalasia are barium swallow, that is big appearance, manometry, hypertension, lower esophageal sphincter and endoscopy to rule out structure or malignancy. The treatment is endoscopic balloon dilatation, that is stretch muscle fibers, leave mucosa intact, forceful dilatation, curative in 75% to 85% of the cases. Hilar myotomy is done, cutting the muscular fibers of the lower esophagus which decrease pressure, either laparoscopic or open surgery. The complications are GERD, avoided by partial fundoplication. Botulinum toxin is an intrasphincteric injection of the botulinum toxin may cause relaxation of the lower esophageal sphincter. The medical treatment is calcium channel blocker, nifedipine, nitrates, decrease lower esophageal sphincter tone. The surgical treatments are Hilar myotomy and peroral endoscopy myotomy. Now coming towards the carcinoma of esophagus. We are having a scenario that there is a 60-year-old progressive. Okay, what we discussed in the achalasia, we discussed the clinical features, the investigations, the treatment options which are endoscopic balloon dilatation, Hilar myotomy, botulinum toxin and medical treatment and surgical treatment. This carcinoma of esophagus is very important topic. The scenario is 60 years old, progressive weight loss, dysphagia for last 5 months, examination unremarkable. Barium swallow shows long irregular esophageal structure in the lower esophagus, weight loss, endoscopy reveals presence of adenocarcinoma at gastroesophageal junction. Sixth most, okay, so what is the surgical approach? The differential diagnosis, the diagnosis and investigation, the risk factors and treatment, the causes and the staging is asked. So it is the sixth most common carcinoma. It spread very early. 25% patients diagnosed at age where cure can be achieved. 80% is malignant. So we are having adenocarcinoma and squamous cell carcinoma. In adenocarcinoma, it is Barrett's esophagus, GERD, obesity, high fat intake, high alcohol intake and smoking. The lower third of esophagus is common and it is 60 to 75% common. While the squamous cell carcinoma, we are having smoking, alcohol, nitrosamine diet, vitamin A, C, zinc and molybdenum deficiency, long-standing achalasia, celiac diseases, HPV, and it is common in the middle third of esophagus and it is the most common histological type. Okay, so carcinoma of esophagus, we are having basically two types, that is adenocarcinoma and squamous cell carcinoma. Now coming towards the clinical features of the carcinoma of the esophagus, these are dysphagia, retrosternal discomfort, extension of the tumor in tracheobronchial tree, stridor, coughing, choking and aspiration pneumonia, hoarseness of voice, paralysis of the left recurrent laryngeal nerve, weight loss and anemia, and the cervical lymphadenopathy. Now what investigations are done? Endoscopy is done, which is the first line investigations, direct visualization of the tumor and histology specimens for accurate diagnosis. CT scan of chest and abdomen is done, extent of tumors, invasion into surrounding structure, mediastinal and abdominal lymph node involvement is done. Endoscopic ultrasound, depth of the wall penetration by tumor, presence of lymph node of metastasis. Bronchoscopy is done for impingement or invasion of main airway. Laparoscopy is done to detect perinatal disease. Positron emission tomography, staging TNM, we are having primary tumor, D regional lymph nodes and distal metastasis. So how stages is done? T1 is the tumor which invades lamina propria, mucosa or submucosa. Then T1E invade lamina propria, muscularis mucosa. T1B invade submucosa. T2 invade muscularis propria. T3 invade adventitia and T4 invades adjacent structures. Regional lymph nodes, we are having a node which is non-regional lymph nodes are involved. In inward regional lymph node, metastasis involved. In N2 to 6 lymph nodes are metastasis. In N3 more the lymph nodes are involved. In the distal metastasis, M0 is no distal metastasis, while in M1 distal metastasis is involved. So this is the staging for the carcinoma of stomach. Now, what are the treatment options? We are having high grade dysplasia or sub centimetric nodule endoscopic mucosal resection. If it is high grade dysplasia or sub centimetric nodule, then endoscopic mucosal resection is done. 41A and N node esophagectomy is done. 41B and node T2 and node esophagectomy plus local lymphadenectomy is done. 43 and N node esophagectomy, lymphadenectomy, and chemo and radiotherapy is done. 44 palliative treatment is done. Okay, then the other options are stunting, laser, ethanol injection, chemotherapy, and radiotherapy. The surgical options are T1 to T3 esophagus undergo major surgery, laryngopharyngectomy is done, chemotherapy and radiotherapy is done. More than 2 by 3rd patients are treated with palliative treatment. These are esophagectomy, Edward Lewis procedure, MC known 3 stages of esophagectomy, and trans-hiatal resection. Now, what are the differential diagnoses of the carcinoma of esophagus? These are esophageal cancer, esophageal diverticula, esophageal stricture, esophagitis, GERD, pneumonia, tumor, and tracheal tumor and zinc diverticulum. The causes of dysphagia are esophageal atresia, FB, thyroid enlargement, rolling hiatus hernia, mediastinal swelling, GERD, and achalasia, that is carcinoma of the esophagus. The contraindications for surgery are systemic metastasis, involvement of vessels, for example, aorta, cervical lymphadenopathy, patients unfit for surgery due to severe cardiopulmonary insufficiency. Esophagectomy should not be performed when a resection is not possible. So we have studied the carcinoma of esophagus, and what are the important aspects? These are: first, we have to identify the scenario. In the scenario, the age will be more, that is 60 to 70 years. Progressive weight loss will be there in the case of carcinoma. If there is dysphagia for last months, then this is the carcinoma of esophagus. Examination is unremarkable. If barium swallow shows long irregular esophageal strictures in lower esophagus, weight loss, endoscopy reveals presence of adenocarcinoma or gastroesophageal junction. So hence we will identify that it is the carcinoma of esophagus. This is the 6th most common carcinoma. Then we are having 2 basic carcinomas. This is adenocarcinoma and squamous cell carcinoma. Then we studied the clinical features, the investigations that are done. This is the endoscopy, the CT scan, chest and abdomen, the endoscopic ultrasound, the bronchoscopy, the laparoscopy, the positron emission tomography. Then we do TNM stages, that is for T is for tumor, N is for lymph nodes, and M is for distant metastasis. Then we discuss the treatment options for all the stages. Then we discuss the surgical treatment options. Then we discuss the differential diagnosis and the specific causes of the dysphagia. Then the contraindications for surgery. Now coming towards the stomach and duodenum. Okay, so first topic that we are having in stomach is peptic ulcer disease. What is peptic ulcer disease? It is focal defect in gastric or duodenal mucosa extending into submucosa or even deeper, leading to bleeding and perforation. We are having duodenal ulcers and gastric ulcers. In duodenal ulcer, 2 to 3 times more common, which are produced by overproduction of acids. First part of the duodenum is affected. Malignancy is less common. Pain relief with food intake. Pain occur at night and common in obese people. In gastric, ulcers are less common, produced by weakness in defense of gastric mucosa, large and involves lesser curvature, high chance of malignancy is present, and it aggravates with food intake. Okay, so how we will differentiate these 2 ulcers, the duodenal and the gastric, by these symptoms. Now, what are the causes of the ulcers? These are H. pylori, the NSAIDs decrease prostaglandin production, smoking, caffeine, spicy food increase production, acid production, ischemia, stress, prolonged steroids intake, and Zollinger-Ellison syndrome. The clinical features are epigastric pain, periodicity, alteration in weight, and bleeding. What are the investigation options? These are gastroduodenoscopy, which is standard investigation. It is done to rule out the malignancy. It is done to patients of weight loss, recurrent vomiting, dysphagia, bleeding, and anemia, and despite of any age. Okay. The second is biopsy, which is carried out in case of gastric ulcer while performing gastroduodenoscopy. The third one is detection of H. pylori, which is CLO test, and carbon-13 labeled ureal breath test, urease test, carbon-13 labeled urea breath test, and stool test, histology, and culture. The fourth one is serum gastrin level, which is baseline serum gastric level is appropriate to rule out gastrinoma. The fifth one is stool test, which is 90% sensitive and 95% specific. The last one is histology and culture of enteral mucosal biopsy. What are the treatment options? These are medical treatment, eradication of the H. pylori, and the surgical treatment. In medical treatment, we will do the PPT step, main step. Then hospitalized patient with complications should be given intravenous infusion of PPI and lifelong PPI therapy after discharge unless causative factor has been eliminated. Advise patients to stop smoking and alcohol intake. Patient requiring NSAIDs or aspirin for any condition should receive concomitant PPIs and H2 blockers. Then the eradication of H. pylori, various regimens, some are PPI twice per day plus clarithromycin 500 mg plus amoxicillin 1000 mg for 2 weeks. PPI plus clarithromycin 500 mg BD plus metronidazole BD for 2 months. Then the surgical treatment is inquire for peptic ulcer may needed for complicated cases. Okay, now surgery for duodenal ulcer are the aim is to reduce the exposure of acid to duodenum, which in turn allows ulcer to heal. Following are various procedures. This is Billroth 1 gastrectomy, Billroth 2 gastrectomy, and gastrojejunostomy. Vagus denervation and drainage procedure, truncal vagotomy and drainage, selective vagotomy and drainage, highly selective vagotomy. Surgery for gastric ulcer is diseased tissue is also removed as this has advantage then malignancy can be confidentially excluded. What are the complications of surgery and what are the complications of peptic ulcer disease? The complications of surgery are recurrent ulceration, dumping syndrome, gastric carcinoma, gallstone formation, and nutritional deficiencies. The complications of peptic ulcer disease are perforation, bleeding, gastric outlet obstruction, and recurrent ulceration. Okay, so what we have discussed in the stomach and duodenum, we have done the peptic ulcer disease, which is duodenal ulcer and gastric ulcer. How we will differentiate between two by these clinical features. Then we discuss the causes and the clinical features of the peptic ulcer. Then what are the investigation options? These are gastroduodenoscopy, biopsy, detection of the H. pylori, then the serum gastrin level, then the stool test, and then the histology and culture is done. What are the treatment options? These are medical treatment, then the eradication of H. pylori, and then the surgical treatment. The surgery for duodenal ulcer, what is the aim? What is the vagus denervation and drainage procedure? And what is the surgery for gastric ulcer? Then we discuss the complications of surgery and the complications of peptic ulcer disease. Now coming towards the perforated peptic ulcer and bleeding peptic ulcer. Perforated peptic ulcer is the common cause of peritonitis. It is long-standing burning epigastric pain or history of intact of insects. Interior aspect of the duodenum is common site. PPU is 10 to 40% mortality rate. The bleeding peptic ulcer is most common cause of death. 70% upper GI bleeding. Incidence increase age and insects, hematemesis or melena, and it is 5 to 10% mortality rate. The clinical features are joint pain, generalized sudden severe abdominal pain, tachycardia, rigid abdomen, abdomen not move with respiration, hypolemia and shock, fever, sepsis, dullness of the liver, pneumoperitoneum. What are the investigation of? These are clinical X-ray chest in posture in erect posture which shows air under diaphragm, and leukocytosis is done for WBC. Ultrasound is done for abdomen, shows free fluid in peritoneal cavity. Serum amylase, that is increased pancreatitis, and CD scan abdomen is done differentiate other causes of acute abdomen. Now what is the bleeding peptic ulcer? The clinical features are hematemesis, melena, minor bleeding, severe bleeding, penetration of the duodenal ulcer into gastroduodenal or lesser curvature, ulcer into left gastric. Okay. Hematemesis, melena, minor bleeding, severe bleeding, penetration of the duodenal ulcer into gastroduodenal or lesser curvature, ulcer into left gastric artery, and early surgical intervention is considered in this case. What is the scenario? The scenario is 30-year-old OPD hematemesis, vomited bright red blood 3 to 4 times in last 6 hours, BP is 100 by 70, pulse is 110 per minute, and endoscopy revealed 2 into 2 centimeter ulcers, which is the aspect of first part of the duodenum. So, what are the causes of hematemesis? What is the investigation and what is the treatment? Okay, the treatment for perforated peptic ulcer is mainly surgical, while the general treatment is stabilize the patient, give the intravenous fluids, NG tube, monitor urine output, intravenous antibiotics is given, analgesics, arrangement of blood, and all investigations are done. Surgery, OT, abdomen open, upper midline incision, wash peritoneal cavity, perforation in duodenum structures, perforated stomach biopsy, Billroth 2 gastrectomy or subtotal gastrectomy, and in post-op we will give the intravenous fluids, electrolytes, antibiotics, analgesics, and lifelong proton pump inhibitor. Okay, the treatment options for the bleeding peptic ulcer. Okay, we will do the resuscitation, that is intravenous fluids, PPIs, transaminic acid reduce bleeding, 75% patient stop bleeding. Endoscopic treatment helpful in form of cautery, epinephrine injection and clipping. Surgical treatment indications are continuous bleeding, unresponsive to endoscopic measures, rebleeding after one or two attempts of endoscopic control, lack of availability of therapeutic endoscopics, visible splinting vessels at base of the ulcer on endoscopy, clot at base of ulcer. Aim is to stop bleeding. Patient resuscitate, abdomen open through midline incision, stomach or duodenum is opened. Biopsy if the ulcer should be obtained if is in stomach to exclude malignancy. Okay. Now, so what we have discussed, first we have discussed the peptic ulcer, stomach and duodenum, the peptic ulcer in the stomach and duodenum, then the duodenal ulcer and the gastric ulcer, its causes, clinical features, investigations and treatment options, then the surgical options and the complications. Then we discuss the perforated peptic ulcer and the bleeding peptic ulcer, then its clinical features, then the investigations, then what is the scenario. Okay, then we discuss the treatment options, then which are just general and surgery for the perforated, and the treatment options for the bleeding peptic ulcers, which are the resuscitation, endoscopic treatment and surgical treatment indications. Okay, here a question is asked in the scenario that what are the causes of the hematemesis. Investigation and treatment are, we have discussed this, that these investigations and these are the treatment options. What are the causes of hematemesis? These are bleeding ulcer, gastric or intestinal varices, tumors in the stomach or esophagus, vascular malfunction of GIT, hemorrhagic gastritis, inflammatory bowel disease, gastritis and esophagitis. Okay, now coming towards the pyloric stenosis, which is also known as gastric outlet obstruction. We are having a scenario that there is a 55-year-old male, chronic duodenal ulcer, which is last from 6 years, and it is having worsening symptoms for the last 10 to 15 days, occasional vomiting of food, and for few days is present, and complaints of foul smelling breath. So what are the diagnosis, management and treatment options? Let's discuss. In pyloric stenosis, we have healing of duodenal ulcers leading to fibrosis and narrowing of its lumen. The common site of obstruction is first far of the duodenum. The clinical features are previous history of the peptic ulcer disease, effortless and projectile vomiting, the absence of bile in vomitus, the presence of partially digested food later hours or days before, and repeated vomiting leads to weight loss, metabolic derangement, succession splash, chronic obstruction, dilate stomach sometimes which reach to pelvis. Now what are the treatment options and what is the investigation? Investigations we will do are barium meal and x-ray, gastroscopy and electrolyte studies done. The treatment options are intravenous fluid containing sodium, nasogastric aspiration is done, and cornate acid based arrangements, and early pyloric stenosis may be done to and resolve spontaneously. Severe cases are treated by endoscopic balloon dilatation or by surgical pyloroplasty or gastroduodenostomy. Gastric outlet obstruction leads to vomiting and excretion of HCl with sodium, which leads to hypochlorite alkalosis and hyponatremia and dehydration. Sodium retention, potassium and hydrogen excretion occur, and hypokalemia and peridoxical aciduria occur. So what we have discussed the pyloric stenosis, its scenario, which are having the features of chronic duodenal ulcer from 6 years, and the symptoms last for 10 to 15 days. Now he is having the occasional vomiting. So what are the clinical features, diagnosis, investigation and treatment? We have discussed the clinical features, the investigations and the treatment, and this is a kind of flow chart which gives us the sketch of the pyloric stenosis. Now coming towards the gastric carcinoma, which is very important topic, we are having a scenario that there is a 40-year-old male patient having a long history of dyspepsia, vomiting especially at evening, pain upper abdomen and weight loss. On examination emaciated pale, succession splanage positive on abdominal examination. Now what is the diagnosis, what are the clinical signs, investigation, staging and treatment? So, in gastric carcinoma, we are having the epigastric discomfort after meal, the major cause of cancer-related mortality worldwide, and late presentation and poor prognosis. What is the classification of the gastric carcinoma? We are having the early gastric carcinoma and the advanced gastric carcinoma. In early gastric carcinoma, there is lesion confined to mucosa and submucosa regardless of the presence or absence of perigastric lymph nodes. and protruding superficial evacuated lesions. In advanced stages, we are having extended to mucosa and submucosa. In type 1, there are polypoidal well demarcated. In type 2, ulcerated with sharply demarcated. Type 3 is ulcerative without definitive measures, and type 4 is diffuse infiltration without significant ulceration. Now, what is the histopathology? It is the intestinal type and the diffuse type. In intestinal type, we are having the polypoidal mass or ulcer, and in the diffuse type, we are having the infiltrate deeply without forming obvious mass. Now, what are the causes? These are smoked food, excessive salt, chronic gastritis, previous gastric surgery like gastroenterostomy, mutations of the E cadherin, and the decreased intake of fresh vegetables and pernicious anemia. These are the causes of the carcinoma. Now, what are the spread options? These are direct invasion, the lymphatic channels, the blood vessels, the transperitoneally. The direct spread is through pancreas and colon and liver, and the lymphatic spread is through lymph nodes. Have identified an involvement or more lymph nodes, poor prognostic. Okay, what are the clinical features? These are early and asymptomatic bloating, distension, and vomiting. Patient with endoscopy should go under endoscopy before treatment. Palpable epigastric mass, tumor may bleed leading to iron deficiency. Tumor may perforate leading to peritonitis. Obstruction lead to dysphagia and persistent vomiting. The physical signs are palpable abdominal mass, palpable supraclavicular lymph nodes, palpable ovarian mass, Krukenberg tumor, palpable mass on digital rectal examination. What are the investigations options? These are gastroscopy, that is exact site of the tumor, and biopsy is done. Endoscopic ultrasonography is done, which define the limit of the spread and identify lymph node involvement. CT scan abdomen or pelvis chest is done. Local extent of the tumor, lymph nodes involvement, and systemic metastasis is done. PET scans are done, which are preoperative staging of the gastroesophageal cancer. Preoperative laparoscopy is done to find small peritoneal implants or small liver metastasis. CBTC is done to check the iron deficiency anemia. Now, staging, we are having the tumor node and the metastasis. In the tumor T1, we are having tumor inverts lamina propria. T2 inverts muscularis or subserosa. T3 invert adjacent organ. In the lymph nodes, we are having N node, no lymph nodes. N1 is metastasis in the 1 to 6 regional lymph nodes. N2 is 7 to 15 regional lymph nodes. N3 is more than 15 regional lymph nodes. M node is no metastasis and M1 is distant metastasis. Okay, now what are the treatment options? We will do the surgery only. Effective treatment offers chance of cure or long-term survival. Incurable, not subjected to surgery. Incurability signs are hematogenous involvement like lungs, liver, and bone, involvement of the distant peritoneal, involvement of the structures that cannot be removed. In surgical options, we are having the subtotal gastrectomy, the radial subtotal gastrectomy, and the total gastrectomy. In subtotal gastrectomy, 5 cm free margin. Palliative treatment, patient present at late stages when time of curative resection has usually passed. Palliative treatment to relieve symptoms. Palliative gastrostomy or gastrojejunostomy may be helpful. Hole outside the abdomen for food intake, anastomosis between the stomach and the jejun. Radiotherapy is done. Poor role in carcinoma of the stomach but is helpful to relieve bony pain caused by metastasis. Chemotherapy is done, which is used preoperatively for inoperable cases to make them operable. So we have discussed the gastric carcinoma. The scenario, which is 40-year-old male patient, long history of dyspepsia, vomiting especially at evening, pain upper abdomen and weight loss on examination, emaciated, pale, succession splanage positives on abdominal examination. So what is the epigastric discomfort after a meal? Then we discuss the classification, which is early gastric carcinoma and the advanced gastric carcinoma. What are the features of early and the advanced? Then what are the types in advanced? That is type 1, 2, 3, and 4. Then what is the histopathology? Then what are the causes? What are the spread options? These are the direct and the lymphatic spread. Then we discuss the clinical features, the physical signs. Then we did the investigations, which are gastroscopy, endoscopic ultrasonography, CT scan abdomen and pelvis chest, PT scan, preoperative laparoscopy, and CBC is done. Then we do the staging for tumor, that is for tumor, for node, and then metastasis. Then we discuss the treatment options, the incurability signs, then the surgery, which is subtotal gastrectomy, radial subtotal gastrectomy, and the total gastrectomy. Then the palliative treatment, then the radiotherapy, and then the chemotherapy. Now coming towards the liver, we are having the pyogenic liver abscess and the amoebic liver abscess. So first discuss the pyogenic liver abscess. This is the pyogenic liver abscess. We are having a scenario that there is a 40-year female patient having fever and pain in the right hypochondrium. Recurrent history of dysentery. On examination, temperature is 101 degree Fahrenheit, pulse is 120, and tenderness in right hypochondrium. So, what is the assessment? What is the diagnosis? And what is the treatment? And what is the what are the assessment options? So, first of all, we pyogenic liver abscess is the most common liver abscess, and the causes are partial or complete obstruction of the biliary tract, which is 40%, biliary tract instrumentation, that is ERCP, stunting PTC, ascending cholangitis or hepatico-jejunectomy, portal venous route, diverticular disease, appendicitis, and inflammatory bowel disease, systemic infections, that is hematogenous bacteria, bacterial endocarditis, pneumonia, tooth infection, IV drugs and abuses, HIV infection, and immunocompromised population. Superimposed infection on amoebic or hydatid disease, direct extension there is subphrenic abscess, perforated peptic ulcer, gangrenous gallbladder, idiopathic and traumatic. Now, what are the common organisms? These are Streptococcus miliae, E. coli, Streptococcus faecalis, and Staphylococci. What are the clinical features? These are pain in the right hypochondrium, high grade fever, rigorous tachycardia, tachypnea, and tender soft liver and jaundice. These are on occasional features. Now, what are the investigation options? These are the WBC is done, that is leukocytosis, increase in alkaline phosphatase check. Ultrasound and CT scan is done, which is sensitive but not specific, although certain findings are typical. Blood culture reveal causative organisms in 50% of cases. What are the treatment options? First of all, you have to give the intravenous antibiotics, which covers gram-negative and anaerobic organisms. Therapy based on the causative organism, and it is given for at least 8 weeks and is effective in 90% of cases. Percutaneous aspiration under ultrasound guidance and correction of the causative factors. Correction of the causative factors and surgery is done. Surgery is done in the case of failure of antibiotic therapy and abscess not amoebic to percutaneous drainage secondary to location. Coexistence of the intra-abdominal disease that requires operative management. So what we have discussed the liver. In the liver, we have discussed the pyogenic liver abscess, which is having the features that the patient is 40-year-old and he is having the pain in the right hypochondrium and having recurrent history of dysentery. And on examination, there is temperature, pulse, and tenderness in the right hypochondrium. So what are the causes? What are the common organisms? What are the clinical features? What are the investigation options? And what are the treatment options? In treatment options, we will give the intravenous antibiotics, the percutaneous aspiration and ultrasound guidance, and then the correction of the causative factors, and then the surgery. Now, coming towards the amoebic liver abscess, we are having a scenario that there is a 40-year-old female patient, entameable histolytica, 10% population, flask-shaped ulcer, common in right lobe of the liver. Okay. What is amoebic liver abscess? It is the entomoebical histolytica, 10% population, flask-shaped ulcer, and it is common in the right lobe of the liver. What are the clinical features? These are fever, chills, malaise, anorexia, weight loss, pain, right hypochondria, mental confusion, and tender hepatomegaly. What are the sequelae of amoebic liver abscess? These are regress if treated with metronidazole. 95% cases can rupture into peritoneal cavity producing peritonitis, and rupture into pleural cavity producing empyema, or into lungs leading to expectoration of chocolate colored sputum. What are the investigation options? These are WBC, leukocytosis common, mild elevation of the alkaline phosphatase, antibody detection for each histolytica, ultrasound and CT scan abdomen is sensitive but not specific. Now, what are the treatment options? These are the medical, which is in which metronidazole 750 mg for 7 to 10 days, 95% success. Then the needle aspiration is done under ultrasound guidance. Large abscess not responding to management treatment. Diagnosis and certainty, rule out pyogenic abscess or tumor, then superficial abscess and left lobe abscess may rupture into pericardium. Then the surgical treatment is abscess cavity contains thick pus and multinucleated large left lobe indicate risk of rupture into pericardial cavity, and then the ruptured abscess. Okay, so what we have discussed in amoebic liver abscess, first scenario, then the definition, then what are the clinical features, then what are the sequelae of amoebic liver abscess, then the investigations and the treatment options, which are medical, then needle aspiration, and then the surgery. Now, coming towards the hydatid disease of the livers, we are having the scenario which states that there is a 30 years old female having pain in right hypochondrium for few months. Ultrasound and CT scan show cystic mass with the daughter cyst in the right lobe of the liver. No fever, no pain. What is the diagnosis? Caused organisms and complications. In this scenario, which states that 40-year-old patient having dull pain in the right upper abdomen for 5 years, imaging shows 5 centimeter multinucleated cystic swellings right lobe of liver. What are the disease investigations, the complications, and the treatment? Okay. Hydatid disease of liver is also known as echinococcus. Cystic echinococcus, parasitic infection caused by tapeworm, dog feces, sheep grazing area cyst form in liver. These substances contain the cyst echinococcus and this causes the hereditary disease of the liver. What are the clinical features? These are the small and uncomplicated cyst, the large and inflamed cyst, pain and discomfort in right upper quadrant of the abdomen, pressure, infection within cyst, rupture into the surrounding structure, the compression of the bile duct, portal vein, hepatic vein, obstruction gyrus, portal hypertension, and abscess like symptoms. Now, what are the investigations obtained? We will do the ultrasound, the CT scan, which precise into about location, size, morphology, and relation in the investigation of choice. Antibodies to hydrated antigen can be detected by ELISA in 60 to 99% of cases, eosinophils in 25 to 45% of patients. Now, what are the treatment options? These are the medical treatment, the percutaneous treatment, and the surgical treatment. In the medical treatment, albendazole 10 mg per kg twice daily, 3 to 6 months, and 74% is success. Pre-op prophylaxis is done, peri-op prophylaxis is done, and is contraindicated in pregnancy. Percutaneous treatment, that is per puncture aspiration of the cyst, contents injections of the and re-aspiration of the fluid only for unilocular cyst, contraindicated in case of cystobiliary communication. In the surgical treatment, we are having cyst cavity, open contents are evacuated, radical surgery, pericystectomy, and liver resection is done. The complications are biliary leakage, biliary fistula, infection of the residual cavity, cholangitis, and contamination of resulting in the recurrence of the disease. Okay, so we have discussed the hydrated disease of the liver, which is also known as cystic echinococcus, and we have discussed the scenario in which the main feature is the multiloculated cystic swellings. Then we discuss the cystic echinococcus, then the clinical features. Then we discuss the investigations, the ultrasound, CT scan, then the treatment options, which are the medical treatment, the percutaneous treatment, the surgical treatment, and then we discuss the complications.